we're going to talk about C-spine, T-spine, and L-spine next week. We're going to hit anatomy, and then we're going to get into projections. Remember, the only projections we're going to test you on are the ones we cover here or in lab. And the best place to kind of get a summary of that is at the beginning of the chapter with the essential projections. So with that in mind, let's jump into the anatomy. So the vertebral column forms the axial skeleton. For the most part, centered mid-sagittal plane. There are some deviations that we're going to talk about. We'll talk about scoliosis, and we'll talk about primary curvatures, secondary curvatures, and we'll also talk about compensatory scoliosis, which is not a pathology. We'll talk about compression fractures and how that introduces, in some cases, some scoliosis as well. So it forms the axial skeleton located in the posterior trunk and does a lot of stuff for us. One is, you got a lot of muscle and tendinous attachments, ligamentous attachments, but it also protects the spinal cord. So each vertebra has a hole in it that the spinal cord goes through. It's got multiple holes in it, or the vertebra above and below will create a passageway for nerves that come off of the spinal cord as well. So it does a lot of stuff. So what we have, a typical skeleton, we have 33, 24 true, the other they're fused. So you can't really separate them as individual vertebrae, but they're just fused together. It's kind of like the skulls of the bones of a skull. You've got your skull, but you've got individual bones that are fused together to create it. And the ones that are fused are separately in the coccyx and the sacrum. So you've got 24 individual bones. Sometimes there's more, sometimes there's less, but 24 individual bones, and then you've got 2 fused coccyx and sacral segments. Each one can have anywhere, the sacrum's going to have 5, but the coccyx can have 3 to 5 individual fused pieces together. All right, so we've got cervical, thoracic, lumbar, sacral, and coccyx. And you've got curvatures as well. So I'm going to bring this side up. It won't picture mute. Okay, I'm going to bring both sides up because I can't get it to picture mute. I can't get it to do anything. Panel up here is not responding at all to anything. Okay, well, I'll just have to point them out. Okay, all right, so your questions on the test, we'll talk about these curvatures. So you've got 2 primary curvatures, 2 secondary curvatures. Primary curvature is something you're born with, right? So it's there at birth, and the other 2 develop primarily whenever you stand up. So you ever look at a baby's spine and like their back is just straight, right? From top to bottom, their back is just straight. Their neck really is the same to a degree until they start sitting up, and the pressure and the weight of the head creating pressure will give us a curvature in the C-spine. Likewise, whenever we start standing up and walking, then our lumbar curvature develops. So you're going to have questions on that, what's primary curvature, what's secondary curvature. So the primary curvature is what you're born with. That's the thoracic curvature and the curvature in the pelvic bones, the coccyx and the sacral segments. But the lumbar and cervical are secondary curves because they develop over time, right? So you're also going to have questions about which one is kyphotic and which one is lordotic. You remember back earlier in the semester, whenever we wanted to see the apex of the lungs, we had the patient lean backwards, right? You don't really want to do that, but that was one of the positioning possibilities, have the patient lean backwards. What do we call that projection, that position?
Lordotic.
Lordotic, right? So we're going to have lordotic curvatures, which lean back, and then we're going to have kyphotic curvatures, which lean forward. Okay, so now you picture the spine, get to an image of the spine, you take a look at our spine, and do this, because this is kind of short fat. make it bigger, longer, and a little bit more believable. So you look at your lumbar segments, and that's what you've got is kind of leaning backwards, right? Same thing with your cervical. So your cervical and your lumbar are both kyphotic curvature. Lordotic curvatures, as opposed to your pelvic portions, your sacrum and coccyx, as well as your thoracic spine, is a kyphotic curvature. Okay, so you go lordotic, kyphotic, lordotic to kyphotic. So you'll have questions about that. Which ones are kyphotic? Which ones are lordotic? But you're also going to have questions about where your convexity and concavity is. Okay. So word association, a cave. What is a cave?
Hole in the.
It's a hole. It's a hole that you can go into. It's some sort of indentation, right? It goes inside of the mountain or whatever. So cave means, something you can go in. So concave, in this case, would be likewise something that you can go into. So where we have concavity on the posterior side, this is posterior side of the vertebra, and you can tell it's posterior side, the anterior side is just like a wall, right? It's a curved wall, but it's a wall. And the posterior side is where you have the spinous process, those bones that stick out. If you see somebody who's really, really thin, you can see the ridge of those on the back, on their back. Right? So as the posterior portion, cervical spine is concave posteriorly, but it flexes outward. So convex, again, word association, you make a muscle in your arm. What are you doing with your muscle? Flexing. Yeah, so flex, vex, convex would be a bulging outward, right? So it's convex anterior, concave posterior. Then when we get to the thoracic spine, it is convex posteriorly and convex anteriorly. Then we get down to the L spine, and it is convex anteriorly and concave posteriorly, and then it switches again for the sacrum coccyx, and that will be concave anteriorly, convex posteriorly. Okay, so you'll have questions about all of that on the test. Which one's convex, which one's concave, where is it convex, where is it concave, which one's lordotic, which one's kyphotic. So just kind of follow all that away. And certainly if you're a doodler, as soon as we pass out the test, just draw it out if you need to. Okay. Let's get back up to where we were. Okay. And that's pretty much where we need to be. So scoliosis, though, is a different situation where you have a lateral curvature. So looking at this image, you don't have really any curvature side to side, right? But scoliosis is a condition that usually affects young women, girls, really. It's usually diagnosed in childhood, and it's an abnormal lateral curvature. So what you're going to have is a primary and a secondary curve. All right, so you got the pathologic curve that is primary, and then your body is trying to bring center mass back over the lower trunk and the hips, and it's going to curve back around. So what you're going to have is a curve in one direction and a curve in the opposite direction. And it can be subtle, or it can be pretty dramatic. I've had a patient one time. If they'd have straightened her out, if there was any way to straighten her out, she'd probably be, I don't know, she was only about 2 feet tall, but she'd probably double her height. I mean, it was very dramatic, the amount of curvature this woman had. Most of the time it's not that bad, but sometimes it's very dramatic. They can straighten out some of that with what they refer to as Harrington rods, and you'll see these sometimes. What Harrington rods are, if they're still in use, is they are rods, but they've got these little hooks that are separate from them, and the hooks will go on the transfer processes, and then the rods that go into the patient's back, and then the rods connect in between them. And what they do is they try to correct for that curvature with those rods, and hopefully in time develop the muscles that will allow that to remain. I hadn't seen those in a long time, but they probably still have some similar treatment for scoliosis. So that's true scoliosis. We also have what we refer to as compensatory scoliosis. And you might see this on chest x-rays, you might see it on APT spines occasionally. And what that is you got a primary hand, a dominant hand, left-handed, right-handed, or whatever. So you're going to favor carrying things in one hand or the other, left or right. And what you do then is if you carry, like I carry my bag on my right shoulder more than on my left shoulder, it just hangs better. So I carry it on my left shoulder. Well, if I'm carrying it on my left shoulder, what do I have to do to keep my balance? Yeah, exactly. You lean towards the left. So what you're doing is you're flexing the muscles on that left-hand side. In a lot of cases, that's what happens is you get just a little bit of a tilt towards one side or the other. And you see that more in people who do heavy work, construction workers carrying a big heavy toolbox a lot. You'll see it quite a bit, but it's subtle. It's not truly scoliosis. It's just overdevelopment of muscles on one side of the spine causing you to lean that portion of the upper portion of your spine to lean just a little bit. And then finally, we get it's a pathologic scoliosis that a person wasn't born with, and that's usually an osteoporotic patients. And most of the time, it's going to be women because women get osteoporosis at a greater rate than men do. And what happens is you get compression fractures in the spine, and those compression fractures are kind of unpredictable. They can be anterior, they can be off to a side somewhere. And what you may get then is some either increased kyphosis in the T-spine or possibly, again, some scoliosis. My mom, she's 83, and she never had scoliosis until she got older, and now, her upper T-spine takes some curves. She probably has some compression fractures in there. So if you look on page 425, you can see images of scoliosis, and that's pretty dramatic. Again, you've got almost a primary, secondary, and a, what do you call it? Third area. You've almost got three curves going on there. It looks like. Okay, so certain conditions in the spine that you'll see and you might not see, but they are present. So what you've got in construction of the spine, I'll talk about the vertebra itself and the components of the vertebra that you need to know about, but just the overall anatomy. What you have is a vertebra and you've got the disc. So the disc is just a kind of it's a kind of a fibrous thing with goo inside of it. And you don't have a problem with it until you start tearing apart that fibrous junk, right? So the outer portion is real tough, but it can tear. So anybody ever tried to tear a lot of paper in half all at the same time? Doesn't go real well, right? So that's kind of what the fibrous outer portion is kind of like a lot of individual little pieces of paper. So it'll tear if you tear it just right. Tear your notebook in half. If you tear it, kind of splay the papers out just a little bit. You can tear individual, and eventually tear through it. And kind of same thing with your disc. Once you get to the center portion of it, it's kind of like a jelly donut. And the goo starts coming out, and it's still not a problem. All right, you can have a slit disc. That's what they refer to that as, is a slit disc. Or a herniated nucleus pulposus is, the technical jargon for it. But you can have a slit disc that has no consequences at all. It's not a problem until one of the things happens, and that is where the nerve comes off of the spine. If you've got compression on that nerve, now you got a problem, right? So people who complain of sciatica, that's what they've got going on. They've got a compression of a nerve that's coming off of the spine, and it may complain of pain and numbness all the way down their feet. Right? Well, they don't have a problem with feet. They got a problem with the nerve, all the way up the spine. So that's what all that's about. The herniated nucleus pulposus is a slip disc, and it, gives you problems. The other potential problem that you have with a slip disc is that if enough of that goo gets out, you get to a point of pretty much bone on bone, and that's always going to be aggravating. So that's always going to cause some pain. All right, so two main parts to the vertebra. We have the body anteriorly, and then we've got everything else. So everything else is the vertebral arch. And I really need to draw this out. So I may have to go on that other. It's responding. Okay. So we're going to use some word association again. The body is the thing on the x-ray that looks square. It's not. It's more cylindrical in shape. But remembering that we're looking at a two-dimensional thing, so it looks like it's a square, but that's the body. The disc sits on top of the body, and that's the only place that you have a disc. You don't have a disc anywhere else, right? So if you have something, and I'm going to kind of square this off on the back because it's not completely circular object. So if you have something or someone that you think probably too highly of, you say you put them on a pedestal, right? So pedestal is something that holds something up. It can just be a cylindrical shaped thing that you can put like a shelf, a movable shelf, right? So it holds up things. So not a pedestal, but a pedicle is the thing that comes off of the back of the body. All right, so you got the body, pedicle, ale,
It's a great question.
You get the book right there.
That's a great point. That's a great
We're going with LE. Spelling is not my strong suit. Rules of spelling, grammar, all that kind of stuff. Y'all have to figure this out. They're just suggestions. It's just a suggestion. I'm going to do what I'm going to do, right? So, pedicle. The pedicles reach back to the transverse processes. Transverse processes stick out transversely. Ergo, they are transverse processes. Okay? None of these pens were transverse processes. All right, so add to that the complication of trying to write and say something different at the same time. This gets challenging. All right, so we've got transverse processes. So they reach further back into what we refer to as the lamina. And the lamina reach further back until it gets to, and this completes the circle, until it gets to the spinous process. Okay? Let's do that. So what this is the vertebral foramen. Okay, so it's a vertebral foramen because it goes through the vertebra. Where you've got other foramen, where the nerves come off, are the area just above and below each pedicle. You've got a little bit of a hole there, and we're going to describe exactly what those holes look like in the different vertebra. And some vertebra, they come off perfectly laterally, and some vertebra, they come off at a 45-degree angle. So we'll talk about that. But you create a hole so that the nerves that come off of the spine can go through those holes. That's where the problem lies whenever you've got a herniated nucleus pulposus or slip disc, and it goes right back into that area and matches on that nerve. Now you've got a compromised nerve, and now you've got sciatica. Some patients, if they have a bulging disc in their neck, they'll have some problems with numbness in certain fingers, depending on what level it is. All right. So That's where that problem comes in. And that herniated nucleus pulposus, it can mash out anywhere. It can bubble out pretty much anywhere. So if it comes straight back into the vertebral foramen, then it's pushing on the entire spinal cord, and that's a problem. So our fixes for these are to do a number of different things. You know, they can go in and they can remove the disc, but if they remove the disc, they have to put something in there to keep it from falling bone on bone. In a lot of cases, what they'll do is they'll take and they'll fuse the two levels together. So this is actually, the disc is going to be bulging in between two vertebrae. So what they'll do is they'll take the vertebra above, vertebra below, they'll put a bone plug in there, and they'll fuse it together. Okay, so more on that here in a second. But the other thing that they can do, and it's usually a temporary fix, is because this is pushing back into the spinal cord is surrounded by, a sac, essentially, sac of fluid, and fluid doesn't compress. So what happens is it just distorts it, it mashes it into the back of the vertebral arch, and that becomes a problem, right? So now you've got all this electrical conductivity that's just kind of mashed together, and you're going to have pain. So what they can do is give the water a place to go, essentially. So what they'll do is they'll come in, and it's kind of like relieving pressure. They'll just take out a portion of the lamina, and that's what we call a laminectomy. So a laminectomy, I got a laminectomy, I couldn't come up with a title. Laminectomy is where they remove a portion of the lamina just to relieve some of the pressure. So if you do a surgery rotation, and they have, like neuro surgeries where you're doing clinicals, it's very common. Okay, so they'll be in and out of this procedure in about an hour. If they're doing a discectomy and a fusion, then it's going to take quite a bit longer. So you'll see both of those, and they're interesting cases to see. Those are the cases where I was talking about the stimulators that they use. Very, very important to make sure the patient is completely knocked out for those, and paralyzed for those procedures. Because they get in here and they get too close to the spine, and the spine works off of electric impulses, or nerves do. And the knife that they're going to use in surgery, for the most part, is going to not only cut but cauterize all at the same time. So it kind of stinks, smells like burning flesh in there. So be prepared for that if you've not been to surgery yet. They use that quite a bit. But if they've got an electric knife and they get too close to a thing that works off of electricity, what do you suppose you're going to have? The patient's going to move all of a sudden. Don't want them to do that. So what we're going to do is give them a paralytic, knock them out, give them a paralytic so that they can't move. So that's the purpose for that little stimulator I was telling you about, physics. All right. So any questions on the vertebral anatomy? We'll look at the intervertebral foramen here in just a second and what it looks like. So the vertebral arch is formed by those things that, I guess I can turn those back. Vertebral arch is formed by those things that I was talking about before, the pedicles and the lamina. Just describes everything I just drew. So we're going to go on past that, and that's what it looks like. So what you also have, though, are articular surfaces where the vertebrae themselves articulate with each other. Okay, so that's what we refer to as a facet. And when they come together, you got a facet here on top and another facet on bottom. So it's a superior articular process and an inferior articular process. So the superior articular process articulates with the inferior articular process of the vertebra directly above it, right? And then the inferior with the one directly below it. So where they come together, you've got this inferior vertebral arch, and when you put two vertebrae together, that is your intervertebral foramina. Okay, not to be confused with your vertebral foramen. Intervertebral foramina is intervertebral because it takes two, right? You got state highway, just goes through your state, right? What's the name of the highway that goes through all the states? Interstate, right? So intervertebral foramina is intervertebral foramina because it has, it goes through two, right? Vertebral foramen, just the one. That's where your spinal cord is. That's where your nerves come off of the spinal cord and come out of the spine itself. All right. So the facets, the articular processes on the facets, or the articulation between individual vertebrae. You may have heard of somebody getting facet injections, right? I had to go get injections, cortisone shots in my neck or back or whatever. Anybody? Not anybody ever had it, but because y'all are probably too young to do it. But very common. They'll get arthritis, and so they'll inject the facets, right? Where they come together, though, they call that a zygapophyseal joint. And they've complicated this over the years. It was originally a facet joint because it was two facets that came together. And then they said, well, let's call it a apophyseal joint. So they changed it to a apophyseal joint. Much longer word, harder to, wrap your mind around. That wasn't enough, so they decided to call it zygapophyseal joint. So zygapophyseal joint is a facet joint, is an apophyseal joint, all really essentially mean the same thing. And it is articular processes where this meets that in two separate vertebrae. Okay. This one on the outer portion right here is something that we'll touch on again next week. This is specific to, that's a facet as well, but this particular facet and this one here are going to be particular to one specific vertebra. So what vertebra do we have that have articulations with other bones, not necessarily vertebrae?
Thoracic.
Bingo, thoracic. So this is where the ribs plug in. Okay. So on the test, you're going to have pictures, diagrams, and descriptions of vertebra. And there's only one type of vertebra typically that's going to have rib facets, right? So if you see a diagram or a description that has joint locations for other bones aside from vertebra, that's going to be that's a vertebra. So every type of vertebra is going to have something specific and unique about it, and I'll point out the other ones as we get to them. So in a cervical vertebra, you've got seven. Typically, you've got seven. And the unique features of those is that, one, it's got a very long spinous process, relatively small body, but the spinous process is also very minimally bifid, meaning that it's forked. It's got a very small fork way back to back. The other thing is that it's got a transverse foramina. Okay, so this is not the same thing as the intervertebral foramina. This is foramina, the transverse process, so that the vertebral artery can get up into the brain. Right? So if you see a vertebra that's got a hole out here, you've always got a hole here, regardless of what vertebra it is, right? But if you've got a hole here, and this is C1, so it's going to be a very small hole or very small transverse process. But if you see a hole in the transverse process, it's only going to be one type of vertebra. That's going to be cervical, right? All right. So what we've got with our with our cervical vertebra is that stuff, but we've got two vertebrae that are a little bit unique, and that is C1 and C2. So C1 is what we refer to as the Atlas in Greek mythology. Who's the guy that holds the globe up? Atlas. That's him, right? So Atlas is the guy holding the globe up. Atlas vertebra, C1, is the vertebra that's holding, your head up. Closest thing you've got to looking like a globe. And C2 is axis. So where we've got most of the rotation in the skull is between those two vertebrae. So the unique thing about C1 is that it really doesn't have a body. Let me get to the picture a bit again. So it doesn't really have a body. You know, this is C1. It doesn't really have a body. It's got these very short transverse processes. It's got a great big hole right there. And then this thing right here is really kind of underrepresented on this image. But what this is this thing, the very tip of this thing right here. Okay. So this is, well, first off, let's go back to this axis. What does that sound like?
What it spins on.
Something that spins on, right? So on your car, you've got an axle, right? And the axle is what your tires spin on. Okay, so that thing is the odontoid process. The entire vertebra is what we refer to as that system. This is where you get the rotation of your head. C1 spins on top of C2. C2 goes up through the anterior portion of C1. Okay, so the dens or the odontoid process goes up through the anterior portion. Again, it's not that small. Back here, what you've got is brainstem, right? So you got this massive vertebral foramen because a portion of your brainstem sticking down through it. All right. But everything else, you know, you got articular processes. These blue things are always going to be articular processes. You've got these smooth finishes to them. That's what they represent as articular processes. So posterior arch doesn't really have a transverse process, doesn't really have a body, very short spinous process rather, very short transverse processes, still has the hole in it though, the transverse foramen. The odontoid process has a massive body, and it's got this big, they say, tooth-like projection off the top of it, and that is your dens or your odontoid process. Okay. So the rest of them, all the way down to C7, are really pretty typical, and the only difference between them is each one is smaller than the one directly below it. So they just increase in size. No real other differences in features until you get down to C7. And C7 is that the spinous process of C7 is that knot that you can feel right at the base of your neck on the back. Okay, that's what we refer to as a vertebral prominence. It's that knot we feel on C7. All right, so all the other vertebrae kind of look like this. We have then is a hole in the transverse process. So we have the transverse foramen. We got the body. We got articular processes. We've got a bifid spinous process, and then pedicle, lamina, all the other stuff as well. Okay. Any questions on C-spine anatomy? Okay. Then it's going to projection. So patient preparation, what you want to do is you want to make sure that you get all the artifacts off the patient. So if you're going to do AP and lateral, your series, your minimum series is really, they may call it a 2-view, may call it AP and lateral. You almost never do a 2-view for the C-spine. Okay. You almost never do a 2-view of the C-spine. And I'll explain that here in a minute. But you want to make sure you get artifacts off, and that includes teeth, right? So if a patient has dentures, those have to come out. If a patient has a necklace on, that has to come off. Anything that can come off the patient, earrings need to come out as well. Okay. So, remove all artifacts. Everything else is, the same as everything that we've talked about before in preparation of the patient. So move the patient as little as possible. If you've ever had any kind of neck pain, it can be kind of positional. I don't think it's as bad in most cases as what shoulder pain is. I've had both, and shoulder pain, in my experience, is worse than neck pain as far as positionally goes. But move them as little as possible. If they're on a backboard and they're in a collar, you don't do anything with them. You don't get them off the backboard. You don't get them out of the collar. That's above your pay grade. Okay, so somebody else has to do all that. You can move them with the backboard onto the x-ray table, or you can shoot them on the table that they're on, but you can't get them off of that backboard. You can't get them out of that collar. ER doc has to do that. So as your trauma patients, non-ambulatory patients, they're probably going to be on a bed, so just move them over onto the x-ray table. If they're walkie-talkie, if they come walking in, then you've got some options. You can either do it, all your projections standing up, or you can put them on the table. Me personally, I like to put them on the table. I have more control over the patient. The patient's going to be more stable and less likely to move if I have them on the table. Your mileage may vary. You may have good outcomes with the patient upright. I do not. Okay. So most of the projections, we're going to shoot at 40 inches. Some of them we're going to shoot at 72 inches. Anytime we increase to 72 inches, what are we trying to accomplish?
Better SID,
Increase SID does what for us?
better
Decreases
image.
magnification.
What's that?
It decreases magnification.
Decreases magnification and increases sharpness of recorded detail, especially where we have an increase in OID, right? So we'll get there here in a minute, but most of our projections are going to be at 40 inches. We can use less than 40 inches, and I'll explain that when we get to the open mouth odontoid here in just a minute. But in all cases, of course, what you want to do is you want to follow hospital protocol. All right, so these are all the projections that we're going to be talking about. So quite a few in the C-spine. We're going to talk about Fuchs, open mouth odontoid, AP axial. We're just going to call it an AP, but it's an AP axial, always an AP axial. Lateral, a couple of different laterals. Hyperflexion, hyperextension is just with the patient bending their neck, and we'll talk about that. And then we'll talk about obliques as well. Okay. So radiation protection for the most part is going to be your collimation. The patient instructions pretty much just be still, except for whenever you get to the open mouth odontoid, you may have a patient go, ah. You almost never see the text do that, but it's in the book, so it's testable all the way through the registry. Okay. So AP axial. What we're going to do, I need to be, I need a skull, I need a skeleton, I use my own head here. All right. So what we're trying to accomplish with AP is we're trying to get the central ray as parallel to the vertebra and the disc spaces as possible. Remembering that we've got a lordotic curvature, it's going to be impossible to completely get it like that. It would be more possible to get it closer by shooting PA than what we would AP, but you're never going to shoot a PA C-spine, just not. Primarily because a lot of your C-spines, they're going to be trauma situation, and you can't very well take the backboard and flip the patient over, and shoot them PA. So you're going to shoot them AP. The other thing that we're going to try to do is try to minimize the amount of superimposition that your chin or the base of your skull is going to put on the upper portion of the C-spine. So the key to C-spine positioning in a practical sense is to take a line that goes from right where your nose attaches to your lip. That's what we call the acanthion. We're going to beat that to death next semester, but that's the acanthion. All right, so a line, imaginary line that runs from the acanthion out to your ear hole, and that's what we refer to as the external auditory meatus. It's on the outside, it's for hearing, and it's a hole. So it's the external auditory meatus, the ear hole. So an imaginary line that runs from one to the other. We want to put that parallel or perpendicular to something in almost all of the views of our C-spine. And what that does is, if you can imagine the central ray coming straight into my neck, right? Now take that line, and that line is tucked down like this, then what, hint, hint, is going to be over the upper portion of my C-spine? Chin, right. So if I'm way back like this, what's going to be over it? So the base of my skull, right? So if, though, I've got it parallel and my central ray is going to be 15 to 20 degrees cephalic, if I were to shoot straight on, my chin would still be over it, right? But if I shoot with a 15, 20 degree cephalic angulation, it's going to place my chin, it's going to project my chin pretty much right onto the top of the base, or right onto the base of my skull. Okay? So a canthomeatal line needs to be perpendicular for the AP. It needs to be perpendicular to the image receptor. Okay? So what if the patient's in a collar? You can't do that. You can't move the patient if they're in a collar. You're going to see some weird things if you happen to, be involved in a trauma situation. A lot of times they're going straight to CT now, which is probably a good thing. But if you happen to get a patient who's in a collar, you'll find their chin tucked way down inside of the collar. You'll see them kind of turn, twisted in the collar. Just shoot it as it is, right? You're not going to take the front of the collar off and straighten the patient up before you make the image. So just go ahead and shoot them as they are. Take what you can get type of situation. But if the patient's out of a collar and they can move, a canthomeatal line perpendicular to the image receptor, and this is as if I'm shooting this upright, AP is going to be 15 to 20 degrees cephalic angulation. Okay. Oh, also, it's going to be 2C4. So, this kind of follows the same rule that we talked about before, and that is where you put your central ray. Anything that we're shooting, where do you put your central ray? Middle of the anatomy, right? So how many vertebrae do you have? You've got 7 cervical vertebrae, right? So 1, 2, 3, 4, 5, 6, 7, right in the middle, right? So it's going to be right around the thyroid cartilage where you're going to direct your central ray. So the difference between the 15 and 20 degrees, you're probably not going to see on even all the way through the registry this specific question. You'll probably see one in your critique class in your second year, but all the way through the registry is probably just going to say 15 or 20 or 15, 20 degree, give you the entire range because that's what's in Merrill's. Some of your other textbooks will dial it in a little bit tighter and they'll say that you need the 15 degree angulation if the patient is laying down. The reason for that is because when you're upright, again, you've got that secondary curvature because of the weight of the head, right? So if you're laying down, you don't have that weight causing the exaggeration of that curvature. Also, you got gravity pulling all the way across your spine. The curvature is still there. It's just not as significant. Okay. So with the curvature being less significant, you only need a 15 degree angulation. If the patient's upright, you need 20. Okay. So that's the purpose for the range. So notice though that it doesn't say that we're going to see all the way up C1 and C2. Even if you position perfectly, you're just not going to see them because of where they're located and the fact that you've got this big, round thing sitting on top of them. So you're not going to see C1 and C2 very well. You might see a portion of it, but you're not going to see it very well. So we're going to have specific views to see C1 and C2.
Sorry to interrupt. Who had a ticket for the projector? Are they working properly?
Yeah, they are.
Thank you.
Yeah, thank you. All right. Any questions over APC spine? Should look like that. And realistically, you see this big round thing here? What do you suppose that is? It's base of skull. All right. So it's not perfectly positioned. It's pretty good, but it's not perfectly positioned. You should see, kind of a squaring off right around in here, and that would indicate, the lower mandible. So it's not perfectly positioned, but it's pretty good. So what you should see then is you should see that right there is your spinous process, and it should be in the disc space of the vertebra directly above it. right? So open disc spaces, these little pointy things here are what we refer to as the uncinate processes. And if your angulation is too great, then they get real sharp looking. We'll take a look at that again next year in your sophomore year.
So with collimation, it needs to be like 10 inches long, right?
Yeah, I would go with 12. So what you want to see is you want to see as high up on the C-spine as possible, and then you need to get all the way down to T2. Minimum T1, but you really want to get to T2. So I'd go with to the skin line, 12 inches. Yeah. Okay, so open mouth odontoid is what we refer to as the Ottenello method. Or I'm sorry, the open mouth odontoid is not the Ottenello method. We're going to talk about the Ottenello method after we talk about the open mouth odontoid. All right, so what's the key to C-spine positioning?
And chin out of the way.
Okay, head and chin out of the way. How do we accomplish that?
The degree 15 and 20.
Okay, 15, 20 degree gets us partway there. What positioning?
You
Tip.
need the canthomedial line.
There you go, the canthomedial line. All right, so the canthomedial line, what we're going to do, and it becomes very important on this one. So the open mouth odontoid, what we're going to do is put the canthomedial line perpendicular to the image receptor. All right, so if it helps, you can take you've got those two lines on your collimator, right? So you've got crosshairs. That's what we refer to that as. So the crosshairs, if you put the crosshairs right on the acanthion and open your collimators until that line of collimation is out, as big as the head, and then you can flex and extend the chin until you get that acanthomeatal line perpendicular, right? So use that. Very, very important, to get these as close as possible, the chin and in this case, the upper incisors of the base of the skull, perfectly in line with each other. Okay. So, acanthomeatal line perpendicular to the image receptor, use those crosshairs, but that's not where you're going to center. You're going to center after you get everything in position to the center of the patient's open mouth. And what you're trying to accomplish, again, is to take the upper incisors, the teeth, and put them directly over the base of the skull. Now, base of my skull is right here. Okay? The odontoid process is right here. If I tuck my chin, then what's going to get in the way of me being able to see the odontoid process? Chin. Well, teeth, right? Y'all see that? Okay, so if then I have my chin too far back, again, I've got the base of the skull issue, right? So it's very important to use that acanthomeatal line to try to put them on top of each other. Now, your textbook's going to say use the occlusal plane, and that's all well and good. What the occlusal plane is a line that goes from your teeth all the way out to your mastoid process. Your mastoid process is that thing behind your ear. Okay, it's a hard bone directly behind your ear. So what you're going to have to do is you're going to have to find that, feel of that, and then have the patient show you their teeth, and then you're going to have to flex and extend for that. Now, that is my occlusal plane. That's my EAM, or my acanthomeatal line. They pretty much parallel to each other? Yeah. So now let's go back to the patient who's on a backboard in a collar. How are you going to find this with a patient that's got a collar up to here? You're not. You might try to feel down in there and feel of it, but as soon as you stick your finger inside of that patient's collar, what are they going to do? They're going to start moving around, right? So is that good for a patient with potentially broken neck? The answer is no, it's not. So just get in the habit of using the acanthomeatal line unless you have somebody with some really bad teeth or no teeth at all. And you'll run into both of those in East Texas, right? Then the acanthomeatal line use the canthal meatal line because, you got somebody with busted up teeth. It's kind of hard to use that occlusal plane. Okay. So occlusal plane, a canthal meatal line perpendicular to the image receptor. Put your central array right to the corners of the mouth. You might put your hand on the patient's head and say, I don't want you to move your head, but I need you to open your mouth as wide as you can. I say that because, sometimes you can tell somebody to open their mouth real wide. What do they do? Exactly. So you get everything positioned properly, and then you say, I want you to open your mouth real wide. No. You got to reposition, right? So maybe just put your hand on their head and say, okay, I need you to drop your chin. Might be a better, explanation of what you need them to do. Now, this is where you may have a test question on the registry. I don't think we have a test question on this, but it may be on the registry to have the patient phonate ah. Right? That's what the wording in the book and on the test would probably be. And what that does is it causes the tongue to drop. Okay, so it gets the tongue a little bit out of the way too. Realistically, I've never. If the patient has tongue ring, that might be something that would be beneficial. But I've never, in my career, ever had anybody say, I had to repeat my open mouth odontoid because I didn't have the patient phonate ah. All right. So if you forget that, that's probably going to be okay. All right. So this is what it should look like. So what you've got here is you've got C1. That's what we refer to as the lateral masses of C1. That's the odontoid process. This is not, again, perfect, but it's just, you would never repeat this. But you see that gap right there? Yeah, that's the, gap in between the upper incisors. So the bottom of the teeth are here, base of the skull is there. What you're looking at is just a tilt that is an eighth of an inch, that's not perfect, but it's close enough. Okay. So what we're looking for on this is obviously broken neck. Specifically, what we're looking for is if the patient has fallen and they landed on top of their head, we can have what we refer to as a axial loading fracture. Or if, let's say, somebody's working on a construction site and a big brick falls on top of their head, they're wearing a hard hat, so they're going to be okay. But because suddenly they've got this traumatic weight dropped on top of their head, what can happen is the ring of C1 can fracture. And what we're specifically looking for in that case would be that the lateral masses of C1 would be pushed out a little bit. So you see the way the lateral masses of C1, lateral masses of C2 are lined up on both sides? The lateral masses of C1 would be out wider. That's what we refer to as a Jefferson fracture. Okay. So Jefferson fracture, we can diagnose that. Sometimes we'll have a patient that's got a broken odontoid process. Oddly enough, it would seem like that would be a devastating fracture. To me, it does anyway, but in most cases, patients have a pretty good outcome. And they've got a lot of different possible fixes for that. They can put a screw up through it, and then they put them in a halo. Anybody ever seen a patient walking around with that big thing on their head? It's what we refer to as a halo, and that's just to stabilize the head to keep it from moving until they can fix that, right? And then they can take the halo off and the patient's just fine. So that's open mouth odontoid. Sometimes, especially if you've got a patient who can't open their mouth very wide, then we can do what we refer to as autotomo, okay? And tomo is short for tomogram. So CT, right? What that means is moving x-rays. X-rays that move for a specific reason. You remember when we did the transthoracic humerus and we had the patient move, breathe? Same principle here. If the patient's in a collar and they can only open their mouth this wide because the collar is right there, then we can do something different and we can get those lower incisors out of the way. So if the patient can't move their head and their canthal meatal line is not perpendicular to the image receptor, how can we get not really the patient into the position, but how can we get these two things stacked on top of each other the best we can without moving the patient's head?
Do like multiple, just stitch them together.
Kind of like a tomogram or something. Yeah, but potentially. We actually used to do tomograms. We could do those of the odontoid process. But anytime you can't get the patient to move, what do you do?
The tube.
The tube, angle of central ray, right. So what you would do in that case, if you can't put the patient's acanthomeatal line perpendicular to the image receptor, you can, though, angle the central ray parallel to the acanthomeatal line, right? So you would angle the patient's head, or whatever angle the patient's head is at, you would angle the central ray parallel to the acanthomeatal line to accomplish this same thing, to try to get as much of the odontoid process as possible. Okay, that's step number one. Step number two would be to have the patient be real still, but open. You'd have to use long exposure time, have the patient open and close their mouth over and over and over again. So if you get like at least a 1 second exposure, as long as a 3 second exposure, with the patient just kind of doing a chewing motion, it'll blur most of this out. Okay, so then you can get, the entire C1 and C2. You probably be able to see all the way down to, C7, T1. So if you look on page Ottenello method, it's also referred to more commonly as the wagging jaw. So if you look on page 456, that's what you're looking at. This is Ottenello method. Wagging jaw, so that you can see C1, C2 in the event the patient can't open their mouth very well. Okay? Just kind of file that away if you're taking an x-ray on a patient that they just can't open their mouth very well. I've never used this in context of shooting an entire C-spine. I've only ever used it if the patient couldn't open their mouth for a good open mouth odontoid. Okay? So that was, back here in the points. That's what it looks like. All right. So this is part of the lecture where I always get myself in trouble with my clinical instructors. You know what? This bears some explanation. So why don't we go ahead and take a break, and we'll pick up with the Fuchs whenever we come back from break. I think